Welcome to the May 2023 LACNETS educational event. I'm Kavya Velagapudi, Executive Director of LACNETS.
I'm Lisa Yen, Director of Programs and Outreach for LACNETS.
And I'm Heather Davis, the Associate Director of Advocacy and Outreach at LACNETS.
Today's presentation is on high-grade neuroendocrine neoplasms. A special thank you to our supporters, Ipsen Advanced Accelerator Applications, ITM Pharmaceuticals, Lantheus, and Crinetics. LACNETS stands for Learn, Advocate, Connect, Neuroendocrine Tumor Society. Our name also states the mission of our patient advocacy organization. The LACNETS board includes Donna Gavin, who is the sister of LACNETS founder Giovanna Joy Sembesi, a NET patient, Mary Dunleavy, who has been living and thriving with NET for 19 years. We're excited to share that LACNETS is partnering with the Carcinoid Cancer Foundation, or CCF, to provide support line assistance. For more information, visit lacnets.org/supportline. I'm now going to hand it over to Heather to share some important tips about today's program.
Thank you, Kavya. Our YouTube channel features approximately 300 videos. Use our playlist to find webinars on imaging, PRRT, liver-directed therapy, Theopara, and our annual conferences. Follow LACNETS on social media to stay up to date on our upcoming webinars and NET news. We are on Facebook, Twitter, and Instagram with the handle @LACNETS. And be sure to add us to your safe sender email list. I'd like to remind our audience that LACNETS webinars are created for educational purposes only and do not substitute for medical advice. The views shared in this webinar are the expert's personal opinion. Please contact your medical team with questions or concerns about your individual care or treatment. And now I'll hand it over to Lisa.
Thank you, Heather. Today's webinar focuses on high-grade neuroendocrine neoplasms. We encourage you to visit our high-grade resources page for more resources, including webinars, a special high-grade support group led by Susan Plummer, and the Healing Net Foundation's high-grade patient navigation guide. I'm pleased to introduce our speaker, Dr. Jason Starr. Dr. Starr is a NET expert and medical oncologist from the Mayo Clinic in Jacksonville, Florida. He grew up in South Florida, earned his medical degree in Lake Erie College of Osteopathic Medicine in Florida, completed his training at Mayo Clinic in Jacksonville, Florida, where he completed his internship and residency in internal medicine, followed by a hematology oncology fellowship. As you can see, he has strong Mayo roots. Dr. Starr has co-authored several papers and book chapters, and he has been actively involved in the development and enrollment of clinical trials, which we know is key to getting more information and answers with the hope of leading to more treatment options. Dr. Starr is passionate about education and in particular, educating patients. Despite his busy schedule, he makes time to engage with patients, and in fact, he offered to us to do this event about 8 months ago at the annual NENs Symposium. Dr. Starr says the greatest joy of my career is the interaction and relationships I am able to have with my patients. And in his free time, he also enjoys and values time with his wife and children. We know that he coaches his son's baseball team, and he also enjoys exercise for fitness and stress relief. Welcome, Dr. Starr.
Hi, this is Jason Starr. I'm a medical oncologist at Mayo Clinic in Florida, and I'm happy to be here with you for a LACNETS webinar that we're going to review high-grade neuroendocrine neoplasms and do an overview, discuss some of the nuances of this disease. I think it's really important that the patient community continues to advocate for themselves, and I love organizations like LACNETS who help patients become educated and become empowered with knowledge, because we know that knowledge is power. So the objectives will be to review the classification of neuroendocrine carcinoma, and we'll broaden that a little bit to just high-grade neuroendocrine neoplasms. Questions to ask when you meet with your oncologist, approach to the workup of the disease, and a brief treatment overview. So when you're defining the disease and you're talking about the diagnosis, it's so important to properly name the disease, because that has implications for the treatment. It has implications for the prognosis. It really dictates everything that comes after the diagnosis, which is, a traumatic event for anybody who's been there. and I have not, and I sympathize with those of you who have. So carcinoid is kind of an old term, right? Similar to the Octria scan, which I say, should go to the way of the dodo bird. Carcinoid also should not really be used anymore in the terminology for neuroendocrine tumors. Now, the caveat to that is our friends in the lung carcinoid in that field have not caught up to the neuroendocrine carcinoma or neuroendocrine tumors of the GI system. And so they still refer to lung carcinoid. And so that's one caveat. Now, neuroendocrine tumors are deemed well differentiated. So by definition, if you say NET, you're implying that the tumor is well differentiated. Neuroendocrine carcinoma or NEC or NECs are poorly differentiated, right? And we hear the terms small cell, large cell, and so on and so forth. And so that's a type of neuroendocrine carcinoma, but it can be just neuroendocrine carcinoma, not deemed small cell or large cell. So how do we determine if it's a well-differentiated NET or a poorly differentiated neuroendocrine carcinoma? Well, it really comes down to what does it look like underneath the microscope, okay? So underneath the microscope, the pathologist determines what does it look like, right? What do the cells look like? You could see on the left that the cells are in little nests, okay? You can imagine the darker cells, you could imagine them in little nests, little groups. On the right is the poorly differentiated or the neuroendocrine carcinoma. You could just tell and get a feel that that is a more haphazard arrangement of cells. And that is how we determine well differentiated versus poorly differentiated. So it's really critical. We rely on the pathologists completely to help us and determine, where do we go next? So the way also that we determine how aggressive the tumor is or give more in terms of the nomenclature is something called the Key 67. So what's the Key 67? So the Key 67 is essentially a stain that is done on the cells. So if you have a biopsy, the cells are on the slide and the pathologist applies this stain called Key 67. Then the pathologist looks at it underneath the microscope and determines what is the uptake of that stain. So you could see in this little representation on the left, the green is the Key 67. And you could see it's highlighting a lot of the cells. So that's going to be an aggressive malignancy. But again, this doesn't help determine well differentiated or poorly differentiated. That is the pathologist's call. So once the pathologist deems neuroendocrine carcinoma, it's implied that it's poorly differentiated. The Key 67 is another piece of information that we need to determine how aggressive is the cancer. Here at Mayo Clinic, the Key 67 is done automated because it's very labor intensive for the pathologist. So we have an automated way to do it, which is really nice, using artificial intelligence, to help us out. The mitotic index is a little bit more nuanced and the reproducibility of it is a little more difficult. Essentially, again, the cells are on the slide. The pathologist tries to determine how many cells are dividing at that given time. So that is more difficult to catch a cell in division. So as we talked about the spectrum, this is the spectrum, right? And I'm driving this point home because it's so important. And I see many patients where the disease is not well defined and the patient or the physician doesn't have a good understanding of exactly what they're dealing with, okay? So on the left, you see well-differentiated neuroendocrine tumor, right? And we talked about they're underneath the microscope in little nests. They're very distinct looking. And then based on the Key 67, we call it grade 1, 2, or 3, right? So there's two designations there, well-differentiated and the grade. And then on the right, poorly differentiated neuroendocrine carcinoma, or NEC, grade 3 by definition. So we don't have to kind of determine grade 1, 2, or 3. And then we talked about it can look like small cell, it can look like large cell, or it can be not otherwise specified, which is actually the most common that I see is the not otherwise specified. And then functional versus non-functional, we'll talk a little bit about that. But it's really important to kind of understand the nomenclature, and this is how we get to what the ultimate diagnosis is. So I'm going to discuss a little bit about the neuroendocrine carcinoma, particularly the extrapulmonary, right? So we're not going to talk about lung cancer where you can find neuroendocrine carcinoma. We're going to talk about neuroendocrine carcinoma that can arise from anywhere else in the body, most commonly the GI tract, but then also pancreas, prostate, bladder, skin, which we call Merkel cell carcinoma. So there's a variety of different organs or tissues that these can arise from. So when you go in to see your oncologist, I would imagine it is a very overwhelming feeling. So I always say it's a good idea to write down questions ahead of time so you know, kind of keep you on track for the things that you really want to get to, because you may get thrown off by something the oncologist says, or you just might be really nervous. So it's really important, I say, to write down the questions ahead of time. And patients are actually very good at doing this, but just a reminder. So you want to know, where did the tumor start? This just helps give a better understanding of, okay, what's going on in my body, right? What stage is the cancer? So there's stage 1, 2, 3, 4. Now, this is different than the grade, right? So I see some patients kind of get tripped up because there's many layers, right? So where did it start? What's the stage? Is it a net or a neck? And then what is the grade? So there's a lot of different layers or layers of the onion to peel back. And the stage essentially says, is the cancer where it originated from? Is it still there, or has it spread? And once the cancer spread, it is stage 4 disease. Okay. And then what's the key 67 of the tumor, right? So you should be using that terminology and kind of discussing that with your oncologist so that you're speaking the same language. And if it wasn't done, then I would request that it gets done. And I just saw a patient this week where there was no mention of the key 67, and that's unfortunate. So you asking your oncologist, do you need a glucose PET scan, right? Do I need a dotatate or dotatalk PET scan, which is specific for typically well differentiated, but we're going to talk a little bit about how we can use the dotatate scan also in the poorly differentiated or the well differentiated grade 3. Well, let me take a step back just for a second. So when we talk about the more aggressive neuroendocrine neoplasms, we talked about neuroendocrine carcinoma, but within the well-differentiated neuroendocrine tumor, there's a grade 3, right, that we discussed. The key 67, the proliferative rate, can go all the way up to the 90%. So it can be dividing just as fast as a neuroendocrine carcinoma. And we'll talk about some of the pitfalls that have occurred in patients who are diagnosed with grade 3, because it's a little bit of an orphaned disease in that a lot of the clinical trials that were done for well-differentiated neuroendocrine tumors did not include patients with grade 3. So, that's one thing where I feel like we need to do so much better, is for that patient population, in addition to neuroendocrine carcinoma. And to that point, do I need genetic sequencing of my tumor? And the answer would typically be, if it's a neuroendocrine carcinoma or a grade 3 neuroendocrine tumor, I do genetic sequencing both of the blood and of the actual tissue, the tumor. And then always should broach the issue or broach the topic of clinical trials. Now, the workup. Basics: blood counts, liver function, kidney function. The chromogranin A, we talk about it a lot. It's not typically helpful. Now, with that being said, I'm not against it. I will, on occasion, draw it. It is helpful sometimes to have a baseline, and then you can follow it over time to see, is it going up or down. What I would caution is that not putting too much emphasis or weight in the number. The number can fluctuate. It's very fickle. So I don't mind getting it, but just being aware of some of the limitations of the test. So is your tumor functional? Most likely is not in the grade 3 or neuroendocrine carcinoma setting, right? So it's very rare to see carcinoid syndrome in a grade 3 neuroendocrine tumor, and I've not seen it yet in neuroendocrine carcinoma or NEC. There are rare instances where With a neuroendocrine carcinoma, I have seen hormone secretion, but not in the classic sense of carcinoid syndrome. So I have seen patients where excess cortisol is released from a hormone called ACTH, a hormone called PTHRP, where you see excess calcium. So if a patient has, if you have high calcium level, that might be a consideration. Or the tumor is making a hormone called ADH, and essentially you're retaining too much water, so the sodium goes low. Those can occur in very rare situations, I would say, but important to be on the lookout for that. So genetic testing, we use the term, but what does it really mean? So genetic testing comes in two varieties. One is you send the tissue off. Remember, we talked about the tissue, the tumor being on slides, and you send it, and the genetics of the tumor are analyzed, right? So in the purest sense, cancer is a disease of the DNA, right? So we'll find some alterations in the DNA. Now, whether or not we can do something about it, and what does that mean? This era of targeted therapy, right? And I'll go over an example of that. We wonder, is there something in the DNA that went awry that we can target with modern medicine? Okay, so that's why we would do the test. Now, germline testing, the name kind of throws you off, germline, but in any case, that is testing the DNA that we got from mom and dad, right? 23 chromosomes from mom, 23 chromosomes from dad, 46 chromosomes. So a very small percentage of patients with cancer, 2 to 3%, have some inheritable DNA mutation. So if there's a strong family history of cancer, then it may be worth looking into whether or not there could have been something in the DNA that you inherited from mom or dad that led to the cancer. For neuroendocrine carcinoma, we don't really know of any underlying inheritable DNA mutations. For well-differentiated neuroendocrine tumors, particularly grade 1 and 2, they're particularly in the pancreas, there is something called NEN syndrome. And so, and a couple other inheritable DNA diseases can occur that present with pancreatic neuroendocrine tumors. So something to just be aware of. But when your doctor says, we're going to do genetic testing, typically they're talking about sending the tumor off for testing, right? But the modern medicine, it's also evolved. We are able to do the DNA testing in the blood very often. And the results typically parallel each other. So whatever you're finding in the tissue, you'll find in the blood. The nice thing about a blood biopsy, we call it a liquid biopsy, is that you don't have to put a needle in anything. You just have just in a vein, I should say. You don't have to do a biopsy. And then the other thing is the turnaround time. Typically, a liquid biopsy comes back within 5 to 7 days, while tissue testing can take 3 weeks or so. So that's something to discuss maybe with your doctor about what are the advantages, what could be the advantages of doing this type of testing. I think it's really important that before any testing's ordered to talk about what are we going to do with the information, right? And just have an understanding of what the implications could be with that testing. So this is an example of a liquid biopsy, right? And you could see here that the different colors that you're seeing represent the different DNA mutations that were found in the blood. And you could see on the readout there that many different mutations were identified. One of them is called a RET fusion, which we have an FDA-approved drug to target that. So this was a patient with a pancreatic neuroendocrine carcinoma. And this could have implications in terms of future treatments and could be a big deal. I did a liquid biopsy in a patient with a lung carcinoid, an unexpected, something called an EML4 ALK fusion. And we started a therapy that worked for almost 3 years. So this could be life-changing when ordered properly and interpreted correctly. So a little bit more about imaging in terms of the diagnosis. So we talked about the pathology review. We talked about some of the testing that you would do initially in terms of blood tests. And then we talked about genetic testing. I want to talk about imaging, right? Imaging is really important with this disease. I tell patients that it kind of gives you the lay of the land. You want to see where is the disease present? Where is it active? so that you can come up with the best game plan and have a better understanding of what's going on in your body. So we talk about PET imaging. So this is a special type of imaging where essentially we use what we call a radioisotope that's injected into the vein and goes to whatever the area of interest is, right? So there's two different types of PET. One is a glucose PET. And in that one, we want to look for rapidly dividing cells. Our body uses glucose as its primary energy source. So the cancer will be using glucose as its primary energy source. And so you could pick that up as a differential because the radioactive glucose will go to the rapidly dividing cells. So the more uptake you see on the scan, the higher the metabolism is of that particular area. Let's contrast that to somatostatin receptor imaging. So essentially, what you're doing there is you're injecting the radionuclide, but instead of utilizing metabolism, you're utilizing a receptor on the cell surface. So it's really important to know that when you see the intensity of the uptake on the scan, it's not metabolism. And I see this mistake made often, even by the reading radiologist. All it indicates is the density of the somatostatin receptors present. Okay, so the brighter it is, the higher the density. Now, we don't necessarily know if it increased, for example, from one scan to the next, but the size stayed the same. Does that indicate progression? Not necessarily. So I see sometimes patients going on new treatments for not necessarily justified reasons. So you would say a faster dividing cancer, you would typically do a glucose PET. However, the somatostatin receptors can be present on both grade 3, which actually the uptake on the somatostatin is probably approaching 80, 90%. But on neuroendocrine carcinomas, it's as high as 50%, right? So why is that important? Well, we'll talk a little bit about PRRT, which is peptide receptor radionuclide therapy, which may be an option in certain scenarios. But I'll point your attention to the little schematic on the bottom, which essentially shows you that the higher the grade, or the higher the proliferative index, which is the key 67, how fast are the cells dividing, the more likely that you're going to see uptake on the glucose. Conversely, if the cells are dividing really slowly, then you're more likely to see uptake with the somatostatin receptor as opposed to the glucose, because those cells that are dividing slowly aren't really utilizing the glucose because they're not dividing, rapidly. So that kind of compares and contrasts the different imaging. So we talked about somatostatin receptor imaging. There has been a push to do in neuroendocrine carcinoma and grade 3 neuroendocrine tumor to do both a glucose PET scan and a somatostatin receptor imaging type PET scan. And the reason why is because there can be prognostic value for the glucose one, in that that's a faster dividing cancer. And then also, again, the possibility or the prospects of doing PRRT if the somatostatin receptor imaging is positive. Now, there is some data showing that for neuroendocrine carcinoma or grade 3 well-differentiated NET, that if the key 67 is less than 55%, there may be benefit of PRRT, and I have utilized it in patients with neuroendocrine carcinoma or grade 3 NET. But we really need a clinical trial. The data that we have is really retrospective, meaning institutions or across the world would give the therapy for the high grade tumor and then look at their data in hindsight. But that's not the best way to obtain data to determine if something works. The best way to do that is to enroll patients on a clinical trial and be able to follow patients to see whether it really works or not. So this is just to highlight the differences that you can see with the different PET scans. So in the top left, you'll see that the dotatate scan is positive by highlighted by what's in red, particularly in the liver. The spleen you'll see in the bottom right of that top left, and that's normal uptake. So there's somatostatin receptors in our body, and that's normal. The neuroendocrine tumors resemble their cell of origin, so they also express this somatostatin. But look on the bottom. the glucose PET scan's negative. So what does that tell you? It tells you that that's likely a low-grade tumor, right? It's not taking up the glucose. Now, let's look at the middle one. You see, certainly there is somatostatin receptors present, and then you see a little bit of uptake on the glucose, right? So you maybe have an intermediate grade tumor there. There's a few of the areas where there's maybe what you call hot spots. And then let's go over to the right, and then we'll notice there the dotatate at the top is essentially negative. And then you look at the bottom right, you see the glucose is positive. And they're almost inversely related. You could see a void almost in that top right one where you see the brightness on the glucose. So that tells you that you're dealing with a high grade tumor. So see, it's very important because you can get a lot of what we call tumor heterogeneity, which is essentially some areas have the receptors, some areas don't. And that really does help to determine the best treatment. So just generally speaking, treatments determined by the stage of the disease. Remember, we said that that's one of the questions that's important to ask your oncologist. What stage is my disease? For localized disease, if it hasn't spread, then surgery might be an option in the right scenario. For neuroendocrine carcinoma, for example, when the disease is present in the pancreas or the rectum, a lot of times we take the treatment that we use it for lung neuroendocrine carcinoma and we apply it to pancreas and rectal. And usually that consists of chemo and radiation together, potentially followed by surgery in very select situations. What we don't want to do is too hastily recommend surgery, because what happens there is there's not a real appreciation of the biology of the disease. So what I'm saying is some patients end up having a surgery that isn't going to be beneficial, and I think that's very unfair. So you have to be very judicious in terms of when we recommend surgery for these higher grade tumors, particularly neuroendocrine carcinoma. So if the disease is localized and surgery is done, there is data suggesting, at least for neuroendocrine carcinoma, not necessarily well-differentiated neuroendocrine tumor, that chemotherapy after the surgery could potentially decrease the risk of recurrence. Again, this data is retrospective, not prospective, but it's the best we have, and sometimes we have to use the best data that we have. So for the grade 3 NET, like I said, there are no standard lines of therapy. And that's mostly because the grade 3 has historically been excluded from clinical trials, and I think unfairly. That's changing, especially with a lot of the new PRRT trials where they are including grade 3 tumors. So there are rare instances where in a grade 3 well-differentiated neuroendocrine tumor that a somatostatin analog may be considered. Now, a grade 3 is that proliferative rate we talked about, the Ki67, greater than 20%. So if a patient has a proliferative rate of 80%, probably not best to start with a somatostatin analog. But that's a huge range, right? 20% to 100%. So say the patient has a proliferative rate of 25%, right? It's kind of just hovering on the grade 3. In that case, it may not be unreasonable, depending on the burden of the disease, depending on patient symptoms, if a patient has a relatively low burden of disease. If somebody is not having a lot of symptoms, I think the somatostatin analogs, which are like octreotide or lanreotide, are reasonable. And we do have data from Mayo Clinic there where we looked at our patient population for grade 3, where they may have been treated up front with a somatostatin analog. And usually the therapy only worked for a few months, but there were some situations where the therapy worked on the order of 6-8 months, and that is meaningful. So we talked about PRRT for patients who have receptor positive disease. The data that we have, remember it's retrospective, shows that this generally works better for proliferative rates less than 55%. So again, it's one thing to recommend something. It's another thing to recommend something that has a good chance of working. So what I want to avoid for patients is giving therapies that are ineffective and have potential for toxicity just to do it. I think it's important that if we do something that it's going to have a meaningful impact for you. So for chemo, there's a few different varieties of chemo that we can use. One of them we refer to as CAPTEM, another one FOLFOXIRI, another one platinum etoposide. We can talk a little bit more about these. A lot of the times, these different regimens are chosen based on comfort level and familiarity with that particular regimen. Now, for neuroendocrine carcinoma, as we talked about, grade 3, it's a poorly differentiated tumor. Again, that you're going to see that proliferative rate cut off again. So for Ki-67 of less than 55%, I typically kind of gravitate towards capecitabine and temozolomide, or FOLFOXIRI, or PRRT. For patients with a Ki-67 of greater than 55%, my approach is typically a platinum, preferably carboplatin is my preference, and etoposide. And then the PRRT, as I mentioned, even for neuroendocrine carcinoma, but for a Ki-67 less than 55%, that's where we've seen some benefit, and a meaningful benefit, as opposed to doing the therapy and it, not being beneficial. So what about immunotherapy? And when we talk about immunotherapy, we're referring to checkpoint inhibitors. So I really like this cartoon. It took me a little while to find one that I liked. But essentially what it shows is the tumor cell, right? The bully. And the T cell. The T cell is the orchestrator of the immune system. But in this case, the T cell is being bullied by the tumor cell because the tumor cell is extending its arm, if you will, to the T cell and saying, "Hey, nice to meet you. I'm okay. I'm one of you." The T cell knows something's up, but gives the tumor cell a handshake. Well, to the rescue comes the checkpoint inhibitor, which essentially blocks this handshake, right? Then the T cell, we have to have another cartoon with the T cell activated and ready to go. But this antibody, which essentially this is an antibody that we give intravenously, blocks this interaction. So the T cell will now recognize the tumor cell as foreign and then recruit other T cells to fight the cancer. Now, in theory, we would hope that this would work for everybody, but unfortunately, it only works in very select scenarios. And we'll talk a little bit about that. For well-differentiated neuroendocrine tumors, even grade 3, we really have not seen benefit of immunotherapy or a checkpoint inhibitor. Now, we looked at our patient experience with just one drug immunotherapy for neuroendocrine carcinoma. I had mentioned well differentiated, it really is no data that suggests that it works. For neuroendocrine carcinoma, with one checkpoint inhibitor, we really did not see much benefit. Now, this has been a little bit conflicting. Some institutions have reported a little bit more benefit than others, but essentially, I do not feel, based on the data, that single agent checkpoint inhibitor is valuable in this setting. So this is a trial where we're going to test in neuroendocrine carcinoma whether or not there is benefit of immunotherapy. Okay, so this is the way that we move things forward. This is the way that we come up with better treatments, clinical trials, so that we can answer, hey, is this beneficial? Can we make someone's life better? Can we improve outcomes? Can we improve quality of life? That's what our mission is. That's what my mission is for my patients. So a more promising possible treatment with immunotherapy involves the use of two drugs. One's called ipilimumab, which I won't test you on. It's a little bit of a tongue twister. And then the other one's nivolumab. So this looks like it might have legs. And this is particularly neuroendocrine carcinoma. So if we look here, like I said, we need prospective trials. This is a prospective trial for patients with neuroendocrine cancers. They were enrolled on a trial to give both of these checkpoint inhibitors. And you'll notice at the bottom right, the patients with the high-grade tumors, i.e., grade 3 well-differentiated or neuroendocrine carcinoma, had the most benefit of this dual checkpoint inhibitor. Now, I don't think a week goes by that we don't correspond with our group at Mayo and say, hey, look at this great response we had from the dual checkpoint inhibitor. But for as many patients as we've seen response, we've seen double probably that have not had response. So it's our job to try to determine which patients are going to benefit from the therapy, because otherwise we may be giving ineffective therapy and offering only side effects but no benefit. Now, with that being said, until we know and can reliably predict which patients are going to respond or not respond, I think that it is worthwhile and potentially beneficial to do the dual checkpoint inhibitor, because it could be a home run. You see on the bottom right there was a patient that had a complete response, 100% shrinkage of cancer. We all would hope that that would be our patient. And because we don't know which patient it's going to be at this point in time, I think that it should be in the discussion for any patient with a neuroendocrine carcinoma. So what are the take-home messages? So I don't know if this is a shameless plug, but I do recommend a second opinion with a NET or NEC specialist. I always recommend my patients to advocate for themselves, ask questions. If the oncologist is not comfortable answering them, then I would suggest seeing someone else, because you need an oncologist who's going to be with you through thick and thin, who's going to answer questions and, partner with you. And every patient that I see, I offer a tailored approach to the disease, and all the NET and NEC specialists do, because we know that no two patients are alike, just like no two zebra with stripes are the same. And that's why we've kind of adopted that as the neuroendocrine mascot. And then determine what testing is needed to help better understand the disease. We talked about the PET scan, the glucose, the somatostatin receptor imaging, when you would use one over the other, when genetics are helpful, what's the difference between somatic mutations versus germline mutations, right? Those all very important to sort out. And what I tell my patients is that they end up becoming experts in this disease. And it's not uncommon that they end up knowing more than, you know, their oncologist, internist, other specialists, because it takes time to understand this. And some study, and by attending this webinar shows me that you're willing to seek answers, and understand this disease better. So I appreciate that. And then please seek out clinical trials whenever possible at every branch point in terms of the treatment. Ask your oncologist, hey, is there a clinical trial available? And it's always worth at least asking. So I want to thank you for having me, and I look forward to answering questions and interacting with you all. Thank you.
Thank you, Dr. Starr, for that excellent presentation. It was such a really informative discussion on some key concepts and terms and things that people may generally misunderstand. And we just really appreciate your dedication and how you are someone who really sticks with your patients, as you said, through thick and thin.
Thank you, Lisa. Yeah, it's great to be here. Thank you for inviting me. Yeah, I love advocating for patients. I love empowering patients with knowledge. And yeah, just really thankful for the opportunity, and thank Rich in the background for making me look good with all my ums. But it was a great production. So thanks, Rich.
Well, Dr. Starr, as you know, there's several questions that have come in, and then the audience knows this is for educational purposes only, and we try to general questions as much as possible. So even with some of the questions, you can answer them as you like. But let's get started with some of the questions, if that's okay with you.
Sounds good. Thanks, Lisa.
So this is a follow-up question to something you said in the presentation. How do I find out about my Ki-67 and the stage? My oncologist said she didn't know. The biopsy was too small to get this information. How do I get the information now?
Yeah, that's an excellent question. Sometimes we are faced with this scenario where the biopsy was just a small piece of tissue and you're just not able to get all the information that you need. The most important thing is to know, is it well differentiated or poorly differentiated, right? And so once you have that, at least you have a jump off point to know kind of what category the cancer is in. The Ki-67 is important because, as I mentioned, even for a well differentiated tumor, the Ki-67 can go up to, 80, 90%. My mentor up in Rochester, Dr. Habd Anderson, had a patient in the 90%. So really there's one way to help would be the PET scan, right? So the gallium 68 or gallium 68 dotatate, dotatalk, copper 64 dotatate. As I showed in the presentation, typically a lower grade tumor will have a higher amount of uptake of the radio tracer. So if a tumor is higher grade, typically you won't see as much uptake, right? And on the flip side, as I mentioned, sometimes it's also to have helpful to have a glucose PET scan, because you really don't expect a low-grade neuroendocrine tumor to have FDG or fluorodeoxyglucose uptake, which is the radio tracer with glucose. So that can help differentiate the grade to an extent. It's not perfect, but you can get an idea. And then obviously doing another biopsy is an option to determine the Ki-67. Not ideal, admittedly. But if there's a decision being made and really need the proliferative rate, I think sometimes it would be indicated. So as far as stage is a little different, right? So stage is based on typically the dotatate, or the PET scan, I should say. If it's a high grade tumor, I'll just say PET. The PET scan will help with the staging to determine, did the disease spread.
Thank you. Thank you for that really thorough answer. And, speaking of grades, this question comes up often. Can tumors change grade? And also, can they change from well-differentiated to poorly differentiated? If so, what causes this and what can be done?
Oh, I like this question. Thank you for this question. So tumors can change grade. Most of the time when we see a discordance between the grade is when the primary tumor, say in the small bowel, is a grade 1. Sometimes when we have seen it, it's when you do like the liver biopsy. If there's metastasis to the liver, we'll see a grade 2 or even sometimes a grade 3 tumor. Conversely, you have a grade 2 tumor in the bowel, and then you biopsy the liver and it's grade 3. So that can happen, discordance. And then there is the phenomenon of the tumor has been low grade for the longest time and something changed. And now the tumor is behaving more aggressively, and you repeat a biopsy and it was grade 1 and now it's grade 3. So we have seen that. I don't know that we have like a percentage of how often that happens. It's not common, but what I would advocate for is, if the cancer really has changed, then I would repeat a biopsy to see, is it much higher grade? And to the other point, is it now poorly differentiated? So I'm thinking of a patient, and I published this paper, that had a well-differentiated pancreatic neuroendocrine tumor that did transform into a poorly differentiated neuroendocrine carcinoma. So it can happen. It's described. And I think the take-home message is if something's not adding up, if the biology seems to have changed, if something's just not right, I would recommend a repeat biopsy. And I hate recommending biopsies because I know they're not comfortable. So I'm very, very judicious when I recommend a biopsy.
I think a natural follow-up question is, if a tumor is poorly differentiated, does it ever change to well differentiated? Or if it's grade 3, would it change to a lower grade?
So the answer would be no. Once it kind of, you get into the higher grade tumor, it typically doesn't scale back. Now, what can happen is something called tumor heterogeneity. So essentially, you have some of the disease is grade 3 and some of it's grade 1 within the same population of cells. So if you use chemotherapy, you may eradicate the grade 3 disease for that period of time, but the grade 1 disease, which typically doesn't respond very well to chemotherapy, may be left behind. So that is one scenario where it would maybe appear that the tumor kind of downgraded, but that population of cells was likely there from the beginning.
Yeah, heterogeneity. That's a
Yes,
difficult
yes.
concept, and thanks for explaining that.
Yeah.
So you
Yeah.
spoke a lot about the FDG PET scans or the glucose scans. Should all patients with high-grade neuroendocrine neoplasms get the FDG PET scans? And if so, when and how often?
Yeah, so I would advocate for getting the FDG PET in addition to the dotatate PET because there's a lot of information to be garnered from these scans, and insurance companies don't love it, but the information is relevant and actionable. So some patients, like I said, we talked about tumor heterogeneity. So different grades of disease within the same kind of presentation of that cancer. And so an FDG PET can highlight the higher grade disease, and then the dotatate PET could highlight the lower grade disease, right? Further, you may have uh, a presentation where some of the disease, again, lights up on the dotatate, but not on the glucose PET, and vice versa. So you could have a scenario where you see uptake on the dotatate scan, right? So you're thinking about PRRT because you know the somatostatin receptors are there. But you do the FDG PET and you notice that, wait a second, this didn't light up on the dotatate, but it's lighting up on the glucose PET. So if I give PRRT, it's not going to work in the areas that are only lighting up on the FDG PET. So that's why it's important. There also is prognostic value with the glucose PET in that the disease, when it lights up on the glucose PET, typically is more aggressive and can be associated with not as good of a prognosis. So, I think to answer the question, I would advocate for both PETs. More so probably the FDG, but the dotatate is important because as I mentioned in the presentation, if the Ki-67 is less than 55%, even in neuroendocrine, in a high-grade neuroendocrine tumor or neuroendocrine carcinoma, you could still consider PRRT. So you need the dotatate to determine if the receptors are present, which they are about 70% of the time in neuroendocrine carcinoma, but in the well-differentiated, it's 90% or higher.
Yeah, thanks for that. And actually, this question just came in, which is you addressed much of this, but I just wanted to ask this question again.
Yeah.
Does the FDG avid disease could always be less somatostatin receptor uptake, and is PRT ineffective for FDG avid disease?
Yeah, so you need the converse. So you need to see what the dotatate or dotatalk. I don't want to, we use gallium-68 dotatate, but any of the commercially available PET scans are fine. It really depends on what the uptake is on the somatostatin receptor imaging, because that's the target of the PRRT. So if you see glucose uptake but not dotatate uptake, then the PRRT is not going to work. So it is important. Another reason why it's so important to have both.
Yeah, thanks for the clarification with that.
Sure.
This is a nice question. Good day, Dr. Starr. Can NET
I
cancer
like the
be
beginning there.
inherited? Yeah, can NET cancer be inherited? And I know you touched on this, but if there's anything else you want to add to that. And number two, what precautions is best before or during unrelated surgery, such as gallbladder? Thank you.
So NET cancer can be inherited. Traditionally, when we diagnose somebody with a well-differentiated pancreatic neuroendocrine tumor, we at least think about NEN syndrome. And so, family history is important to kind of gather a family history. Um, with MEN1, invariably, you'll have high calcium. So that can be kind of a tip off that MEN syndrome is at play. Now, for small bowel neuroendocrine tumors, which are more common than pancreatic neuroendocrine tumors, we don't, we're still learning, is what I'll say. When I first started doing NETs, I would have said, no, we don't know of any association. But we've done some work at Mayo, and Dr. Kim Perez did some work at Dana-Farber at Harvard, and we're seeing some relationship with inherited gene mutations in NET. So I can't say that at this point in time, everybody with a small bowel neuroendocrine tumor should have genetic sequencing or what we call germline. Remember, we learned that word, the DNA that we inherited from mom or dad. So I'm not saying everybody should have it, but a strong family history should prompt some genetic testing. So I hope I answered that one. And then the precaution before, during, or unrelated gallbladder surgery. So nothing in particular. I mean, we talk about gallbladder surgeries a lot as it relates to somatostatin analogs, the lanreotide and octreotide, because they can predispose patients to gallstones. So I will say a plug for the surgeons. If you're going to have surgery for a neuroendocrine tumor and there's some anticipation that you may go on the injections, ask the surgeon to take out the gallbladder at the same time. I had a patient recently and I'm like, oh, I wish they would have took out your gallbladder, because then it would have just been a non-issue. Usually the recovery is pretty quick. Now, one thing you can develop after gallbladder surgery is bile salt malabsorption. So some patients need to be on a bile salt resin or a binder, essentially, because you don't have the gallbladder to store the bile. It just kind of keeps flowing out. So some patients, the bile comes out, a little bit too much and not in a more regulated fashion, and you could develop diarrhea as it relates to that. But most patients don't have that.
Okay, thank you for that answer. That's really helpful. And speaking of treatments and somatostatin analogs, what happens when you stop lanreotide or octreotide after a year? What are the symptoms, and does cancer progress even though the shots weren't working?
Yeah, great question. So the octreotide and the lanreotide, I always explain that we use these medications for two reasons. It's a two-pronged reason. So one reason is to control symptoms as it relates to hormone secretion that these tumors can cause. So carcinoid syndrome, right, classically, and most of the hormone that we think of as serotonin. For pancreas neuroendocrine tumors, it could secrete gastrin, insulin, and a few other different hormones. So we could be using the injection for that reason, okay? But what we found out after we learned that it stopped hormone secretion is that it actually slows the growth of the cancer. Now, there's no symptoms per se if you stop the injections if you weren't having symptoms before you started the injections, okay? And there's a debate that this question brings up, is whether or not to continue the injections even though they're not working. If, in terms of disease control, if the injections were started for symptom control, I would continue them. If the injections were started to control the disease, I do not typically continue the injections after they stop working. So that's my practice, and most of the folks on the NENs guidelines, the North American Neuroendocrine Tumor Society, would agree with that stance, because there's no good data to continue the injections if they're not working.
Mm-hmm. Yeah, that's a controversial topic, and thank you for
Yeah,
clarifying the guidelines.
sure.
Speaking of treatments, what's the difference between cisplatin and carboplatin? And when do you prefer carboplatin? Oh, why do you prefer carboplatin? When do you use cisplatin versus carbo with etoposide?
You got a savvy audience. This is actually an area of active investigation that I'm working on some researchers with, and we've looked at the data internally at Mayo, and I think we presented an abstract at GI ASCO regarding this question. And so our data showed that there might be an edge for cisplatin over carboplatin, right? I'm not a believer. Typically, we use cisplatin when patients are younger, more fit. And so the benefit that we saw with the cisplatin might just be a representation of younger, more fit patients. So what are the differences, right? So cisplatin can cause more nausea, it can injure the kidneys, and it can cause ringing in the ears. So those are kind of the big ones, right? Rarely it can cause some neuropathy, rarely. Carboplatin, on the flip side, typically doesn't cause the ringing in the ears, doesn't cause the kidney damage, And the one thing to, and doesn't cause the neuropathy. The one thing that you have to look out for with the carboplatin is it can affect the bone marrow more. So you can see more issues with blood counts. Now, usually it's the white blood cell count, which we can overcome with white blood cell boosters, essentially. I'll use that term. So carboplatin, in my experience, is much better tolerated. Patients have a better quality of life. And I rarely use cisplatin for neuroendocrine carcinoma, except in very unique circumstances. Maybe if I have a patient with a localized tumor in the pancreas and we're doing kind of a chemo radiation approach, maybe I'll use the cisplatin because some of the studies that were done in lung cancer use cisplatin more often. So that might be one scenario. But generally speaking, I'm in the carboplatin camp.
Yeah, thank you for that. And we look forward to hearing more about your studies on this.
Yeah.
So you mentioned blood counts, and this comes up quite frequently. And I know you talked about white blood cell count. What blood counts do you monitor for with treatments? And I know platelets also come up as well. What can be done for low blood counts, or what precautions need to be taken?
Yeah, so the white blood cell count is the one kind of we keep on our eye on kind of three main parameters within the blood counts that you can kind of look at. So WBC is the first. So that's the white blood cell count. That's what it stands for. And then AN is in Nancy C, which is the absolute neutrophil count. The neutrophils are your first line of defense against infection, particularly bacterial infection. So we get nervous when those go low, below 500. Typically, we start getting nervous. And then the other one is hemoglobin, which is abbreviated HGB. And then the other one's platelets, which could be abbreviated PLT. Now, we talked about the white blood cell. We can give white blood cell boosters, which are injections typically that are given in the kind of the lower abdomen. They actually have one device where you can actually put it on the arm and it delivers the dose the following day, which is a little strange, I think, for patients to experience. Now, if the hemoglobin goes low, which we call anemia, we typically would give a blood transfusion depending on, if it got low enough. Otherwise, the hemoglobin typically doesn't get low, to the point where it's in the danger zone, unless there's some bleeding going on or something like that. So transfusions, there are injections for red blood cells too, that I use kind of infrequently, but they are available. And then lastly, the platelets. The platelets are the most, stubborn, because there are some maneuvers that we can do. There's actually injections and there's a pill that can increase the platelet count. They're really hard to get. They're expensive and insurance companies do not like paying for them. Platelets, typically, we get concerned when the platelets get below 20,000, right? So if you see your platelets and they say 80, that means 80,000, and you have more than enough platelets. A normal platelet count is 150,000. So the platelets typically aren't an issue. It takes 7 to 10 days for the platelets to recover. That's the time it takes for, for them to regenerate. So that's kind of how we look at the blood counts. If you're starting on something like capecitabine, temozolomide, make sure your physician's watching those blood counts very closely, at least every 2 weeks at first. And then as you get further out on the regimen, we start trusting that your counts are going to be stable. But at first, just because it's an oral therapy, you still got to watch those counts really closely.
Yeah, you explain things so clearly, and I feel like we could keep talking for a long time. But let's just,
Thanks,
I know
Lisa.
you have a patient to get to, so let's just close with this last question. What closing thoughts or words of hope would you like to leave the neuroendocrine tumor or neuroendocrine neoplasm community with?
Yeah, so we hear you, right? We are working on developing better treatments to combat this disease. We didn't get to talk about, there was one question I think about alpha particle therapy, which is the newest iteration of PRRT, which is we're very hopeful for. We're going to be opening a few of those trials at Mayo Clinic. We're trying to understand the disease better. What are the underpinnings? Like, what triggers the disease? Why does it even develop in the first place? We're working on understanding how the immune system plays a role with neuroendocrine neoplasms. So, we want to enjoy the wave of excitement around immunotherapy that we haven't been able to share with the majority of our patients because it just doesn't work. So we need to find different ways to activate the immune system so that we can also revel in those successes. So the other thing is also it's really important to know that the oncology team that you're working with, we want to hear how you're doing, and your quality of life is really important, because I explained that with most neuroendocrine tumors, the high grade ones are a little more difficult, but the disease can be like a marathon, and so we want to like keep pace. We want to set the pace and be there, side by side, running with you. And sometimes that's hard to conceptualize because it's cancer and it's terrifying. But there's hope, and we need to do better as a scientific community, and we're working on it.
Thank you for your sincere words and your dedication. It means a lot to our community. We really do appreciate all you do at the bedside, in clinical trials and publications and conferences. And we look forward to hearing more from you in the future.
Awesome. Thanks, Lisa. Yeah, my patients are my inspiration, so I'm happy to do this.
We really appreciate you. And now I'm going to send it back to Heather in the studio.
Thank you, Dr. Starr, for that illustrative presentation and addressing those pressing questions from our live audience. Educational programs like these are made possible by our sponsors Ipsen, Advanced Accelerator Applications, ITM Pharmaceuticals, Lantheus, and Crinetics, and donors like you. Please consider making a donation today at lacnets.org/donate. A special thank you to our technical director, Rich Tamayo from TVP Live, for this high-quality broadcast production. Again, follow us on social media to stay up to date on our upcoming events and net news. Our handle is @LACNETS. And now back to Lisa.
Thank you, Heather. We want you to know that you are not alone. LACNETS is a community of resources and support. We offer many programs, including our weekly virtual NET support group, our monthly caregiver-only support group, NET Vitals, our NET communication tool, and a health and wellness coaching program, which is an opportunity for self-care. LACNETS also has a monthly podcast featuring experts who answer the top 10 questions in their field. Our recent podcast is on gastric NET, gastrinomas, and Zollinger-Ellison syndrome. Go to our LACNETS podcast page to check out the transcript, resources, and the 10 questions we asked the experts. LACNETS is here to help you and those affected by NET. If you have questions or are looking for more resources, you can reach out to us at lacnets.org/support line. Thanks for joining us. Goodbye, and we look forward to seeing you on June 17th.